Right, so I wanted to welcome everybody to this webinar. This webinar is organized by the French-American Chamber of Commerce, and we are very excited to have Jean-Marie Maillard with us. Jean-Marie is the medical director with the Communicable Diseases branch of the Division of Public Health at the North Carolina Department of Health and Human Services. We has worked since 1992. He leads a team of physicians, epidemiologists, veterinarians, and public health nurses who conduct surveillance and control activities in support of local health departments and others for about 70 reportable diseases as well as non-reportable communicable diseases. He trained as a medical epidemiologist in France and England and gained public health experience through assignments at the local, regional, national, and international levels. So we will start the webinar with a presentation by Jean-Marie. He's going to talk to us about the situation. And then we will open the line to questions. As you can see at the bottom of your screen, you have a little logo saying Q&A. So you can ask questions in that Q&A. Everyone is muted. To prevent all sorts of noises, disturbing the conference. But you are welcome to put in all your questions, and I will moderate the questions. I will ask the questions at the end to Jean-Marie, and we hope to have lots of answers today. So thank you, Jean-Marie, for being here, and you have the microphone.
Well, good afternoon, everyone. This started as a rather informal webinar suggestion to try to share what I could with mostly the French community. I understand that this opened up to probably a few people from chambers of commerce, and I'm happy to talk to everyone. It looks like we are a fairly small group, 19 attendees, so hopefully that'll give plenty of time and opportunity to have back and forth with questions and answers. I'm not sure I can answer everything, but I can certainly try to explain where we are, what are the approaches used, the challenges, and the forecast, the projections that are being made, and hopefully that will increase your level of understanding of this pandemic. So I've prepared a few notes to go over general topics at first. I'm not sure how long that will use, maybe, probably less than half an hour. And then we can go on and go with a question and answer session. So what is coronavirus COVID-19? There was a consensus to name it that way. That included a number of experts and a desire not to name any community. One of the problems with these new diseases and pandemics, we've seen it with AIDS, we've seen it with this pandemic, we've seen it in 2009, is the community that originates from the part of the world where the disease seemed to be emerging from may be victimized, and so we do our best to avoid that. We've all heard reports of a Chinese community being ostracized or victimized in other ways, and so hopefully this is where we, so the name is COVID-19. The virus got a name too, and it was named SARS-CoV 2019. SARS because it also causes severe acute respiratory distress syndrome, like the SARS outbreak of 2003, 17, 18 years ago. But it's a different virus. So let's start with coronaviruses as a family of viruses. And it's important to understand because there are four types of viruses belonging to that family that actually cause things like the common cold. I mean, it's always been there. It's in the US, like in many other countries. It mostly causes mild illness. It can be more severe in rare cases. But these 4 viruses are also named coronavirus, and they have certain acronym following numbers and letters. And then there are 3 that are much more severe in terms of clinical illness. SARS, which caused an outbreak in 2003 with 8,000 cases and about 10% case fatality rate, mostly affecting southern China, Hong Kong, and then Toronto. The city of Toronto had a terrible outbreak with lots of cases and death, mostly in hospital. And the Middle Eastern coronavirus, which is causing much less cases, mostly associated with exposure to camels and patients in hospitals, but where the mortality, the case fatality rate is over 30%, so very, very severe. And just to, we'll go back to mortality rate a little later. The SARS-CoV is a respiratory febrile illness, so that affects not the upper respiratory system. It does affect to some degree, because that's where we specimens for testing with RT-PCR method. But the damage is really done at the level of the lungs, and this is related to certain types of receptors that are that have a lot of affinity with the virus, more in the lungs than in the upper respiratory system. Now that's the quick description. So fever, 100.4 or 100, and shortness of breath or cough. Cough can be is mostly dry. And I was just talking with a friend who is a family practitioner in the area of Paris, and just returned from a short vacation, and he was saying it's striking how all his colleagues are beginning to say, well, it seems that there is also a phase of losing smell and taste at some point. It seems to be characteristics unusual, but that's something you don't read that much right now, but among physicians talking together, that's what came up. So, of course, now, aside from that, more and more of the discussions at all level in the news and on social media are about people who are mildly symptomatic or asymptomatic, and yet when they're tested, you can retrieve positive RT-PCR results. I'm careful with saying the tests are RT-PCR because there's a distinction between a test revealing nucleic acid from the virus and a test that attempts to culture the virus to make sure that there are viral particles that can cause infection. There's a slight difference with that. With COVID and a number of other diseases, if you monitor a patient using a nuclear acid RNA test, you can pick up positive results for longer than the phase where a patient is contagious. So there's small distinction there. So the outbreak started in the city of Wuhan in China. That's a large metropolitan area with over 10 million population. From there, it spread to all regions of China and quickly through travelers who had been in areas where the virus was in circulation and were mostly during their incubation period. The incubation period is the time that elapses between the moment you're exposed to a virus and the moment you become symptomatic. With coronavirus, COVID-19, this is, we all talk about 14 days, and some studies have gone a little more precisely to describe that 50% of the the persons who become a case around day 5 have already had an onset of symptoms, but it can take up to 14 days. That was based on other coronaviruses, and it seems to hold true. That's not been changed. Spread through initially travelers, and that's why we saw some restrictions on travel from China. Not complete though. People who were residents and citizens of the US could continue to come back. The normal volume of travelers between China and continental US is about 22,000 per day. That's enormous, but that is, we learned during SARS that it was about 20,000 at the time. That's in the absence of issues like what we're experiencing now. It's fallen down. The last time I saw a number, it was down to 2,000. No American airline is flying to China, as far as I know. The few Chinese planes that come in bring in just a few travelers, 10% or 5% of what it has been in normal days. And they can only come through 11 selected airports where there is an effort to screen and inform travelers about the need to self-quarantine, self-monitor for symptoms for 14 days to be sure that they don't become a case. But quite frankly, at this point, a lot of things have evolved very quickly, and the geography in particular, what was relevant 2 months ago, has lost a lot of its relevance today. I mean, it's true that we saw the travel concerns extended to Europe when there were large outbreaks in Italy and Spain and other countries, in France. But it's also now well established in the US. I looked at 3 p.m. this afternoon, and I think the total was something like 133,000, almost close to 133,000 in the US, with currently 2,351 deaths reported. Now let's talk about numbers. When we hear about confirmed cases, well, that's the results of tests. And these numbers are a function of how much you test. And we've all heard that there are not enough tests compared to what we would like to have. And therefore, and there are many different reasons for that, but in large part, it's the capacity that maybe sometimes pre-existed the outbreak, like in South Korea. They went through really bad outbreaks in the last decade, and they were prepared. They had a lot more resources lined up to be able to quickly test large numbers in the population. And what that leads to is when you look at case fatality rate and you just look at confirmed cases and number of deaths, there are a number of technical reasons why this needs to be taken with or interpreted carefully. The first one is if you don't test a lot, like we saw in Iran, for example, then, and it seems in Italy as well, possibly, although there are other reasons there for a high case fatality rate. If you don't test a lot and you count your dead, there will be a larger proportion of your confirmed case. The way to get to the real case fatality rate is to test widely and therefore increase the denominator to include as many as possible. Now, if we were able to, if we had enough tests to liberally test people who are having very mild symptoms, who at present we're saying, if you feel well enough and you have compatible symptoms, stay home. That's the best thing to do. Isolate at home. Technically, there's distinction between isolate and quarantine. If you're sick, we say isolate. If you are exposed and don't know if you're going to become a case and told to stay home, that's technically quarantine. So we're not asking these people request a test. First, because we don't have enough tests. Second, because if they have the disease, we don't want them to expose healthcare professionals who do this test and collect the specimens. Third, we don't want to waste precious resources of personal protective equipment because there's a shortage in masks so far. And fourth, if you don't have COVID-19 at that point, and you go to a place where people are being tested, you might get it there. So they're back to, ideally, if we could test everyone, we'd have a better sense of what is the true case fatality rate. We would see lower rates than what is mostly broadcast. So countries that have tested very extensively, like Germany, Singapore, they have rates below 1%, which is, you know, a good thing in some ways. Now, the other way to look at this is just to look at the absolute number of deaths, and this is very high by all measures, and so it's still a huge concern, but the case fatality rate is not what you read when you just look at a number of reported confirmed cases versus death. Compare a normal flu season has a case fatality rate of about 0.1%. So back to what we seem to be seeing here, the case fatality rate of COVID-19 is 10 times what we experience with the regular flu. And the flu is not the same every year. There are years that are worse. We have H3N2 that affects more the adult population with a higher case fatality rate. In 2009, it turns out what technically was a pandemic, and we'll go back to that, was mostly a milder disease. And there were still 12,000 deaths, and many of them were children. But in terms of case fatality rate, it was very low. Of course, the measuring stick that we can use here is the Spanish flu of 1918. And the Spanish flu had estimated average case fatality rate 0.5%, so much higher. And thankfully, medicine has made lots of progress since then, years. But when we're faced with a newly emerging virus and no one is immune, and as we are seeing currently, there's not good therapeutic option for vaccine, even 1% is terrible when we have so many cases. Let me just briefly pause to make sure you still hear me. Marie-Claire and
yes.
Alain,
Yes.
Okay, thank you.
Yes. I just muted myself because I didn't want to make any background noises, but yes, we can.
Sure. So that's beginning for an introduction. Pandemic, by the way, is a technical definition. It just means sustained transmission in more than one continent. So we saw it transmitted very intensely in China at first, and then we saw a lot of cases, but for a while, these were imported cases with a few secondary cases around the patients that had traveled. And the World Health Organization waited a while before formally a few weeks ago that this was a world pandemic. So that's where we are. How do we respond in terms of public health to a pandemic when we don't have a vaccine and we don't have treatment? Well, initially we do it the traditional way, which is we're going to do what we can to detect cases very rapidly. People who are cases, make sure they don't expose others. So if they're well enough to stay home, that's the best place to be. Or in some countries, there were decisions to take a harder stance and isolate cases in specific designated area out of their households. If they are too sick, it's isolation while receiving symptomatic care. The care can involve testing drugs and therapeutics that may or may not gradually, hopefully, will be more available. We'll talk a little more about that later, but that's isolation of the cases. Another, we could call traditional way to deal with this pandemic is to quarantine people who were exposed for long enough that if they were to become cases, they're not going to expose others. It turns out it's extremely important if persons who become cases can start transmitting before onset of symptoms, like we see with measles. You have to go back 3 days before the onset of rash. That complicates control. It looks like it's possible with COVID. The proportion to which it happens is not clear yet. But as we learn and as we have more data, the use of quarantine for the purpose of limiting the spread is a good thing. And then you see all the personal measures that have been given since many weeks now. Wash your hands carefully, etc. Clean surfaces, cough in your shoulder. All of this is really a mix of, so the primary route of transmission is respiratory droplets. That's when, and so when do we emit respiratory droplets? When we talk, when we sing, when we sneeze in particular. And so it's people who are symptomatic with cough who are mostly spreading the disease. And it turns out with coronaviruses, it's been shown with SARS, and it's quite possibly happening with COVID as well, certain people who are super transmitters. They have viral loads that are higher than the average. And when studies carefully review all the information available after very contact tracing and monitoring of contact during their quarantine, some people lead to way more than others. Now that leads us to another technical term, which is the reproductive rate. The reproductive rate is an index that measures how many new infections result from one patient. So one case causing one secondary infection would be pretty much a flat epidemic curve, not an exponential like we're seeing. If it's above one, the outbreak will increase in size. If you manage to tweak your reproductive rate, which is sometimes written R0 with a small zero or R. If you manage to bring the reproductive rate to less than 1, then you're in the direction of controlling your outbreak. This is easier said than done, and that's going to help explain why we are in the current situation with regard to instructions that politicians and other leaders are giving now. So for COVID, we've seen a reproductive rate of around 2 to 3 in some early reports, and then less when more was known. It is probably, so the way to reduce that, if you have a treatment, is to treat people early, to detect them early, to make sure they don't expose others when once they are contagious, to keep those who are exposed separate from the community. All of that plays, but is not sufficient. At some point, to take other types of measures. So this is the first type, which is called containment. So we go around cases, we do what we can, and we also use personal protective measures. The cough etiquette, the hand hygiene, that's about droplet spread. The hand hygiene is a combination. It's about droplet spread and possibly contaminating your hands when you sneeze. If you're doing a tissue, so when you throw that tissue, you wash your hands carefully, 20 seconds after that. But it also has to do to some degree with the risk of these droplets ending on surfaces, and they have viral particles that can remain live for a few days. And so that's where you see the recommendations for cleaning high-touch surfaces. The nature of the surface can play in how much the survival is. It looks like cardboard, paper types, porous types are not great, but it's still over 24 hours. Things like plastic and metal can be longer, 3 to 4 days. Certain metals affect that, and for copper, for example, it's not as long as for other metals. So these are all the measures used during the containment phase. When we are in a community like we are in North Carolina now, where you start detecting community transmission, and that means we start having cases, newly diagnosed cases, where we cannot say how they were exposed. So up to a certain point, we were dealing with people who had traveled themselves, people who were exposed to symptomatic people who returned from areas where there was a lot of transmission, or people living in household of a case. And so at some point, and we've passed that phase more than a week ago now, we start talking about community transmission. And at that point, containment is not enough. You need to move to another approach that's called mitigation. And mitigation is looking at all the factors that participate to the transmission, the spread in the community. And so obviously, you know, when people are mingling together in mass gatherings, or, you know, we've decreased the size gradually from 1,000 to 500 to 100 to 50. And the president even talked about avoid gatherings of 10 people or more. All of that has to do with, that's how you reduce the chance of transmission from person to person. The travel restriction were part of the stay at home. Well, first, the work from home if you can, and that's where we benefit from the technology of today. Mitigation has been used in the pandemic of 1918. It's been used in other pandemics since then, all influenza in 1957 and 1968 and 2009. All of that, it's because we do not have perfect measures, and the goal of that is not so much to get to suppression, to stop the outbreak with these measures. It's to reduce the opportunities for the virus to go from one infected patient to a susceptible person and spread with, you know, resulting in additional cases. I'm sorry, I'm reading some of the question. I've not been able to keep up with the question. We'll get to that later. The mitigation is to buy time, because when you start looking at projections and you look at the increase, which is exponentially going up very rapidly, even if there's a fraction of the cases, large studies in China showed that out of a series of 71,000 patients, about 81% were not very symptomatic, and they you know, stay home, and they did not need hospitalization. 40 needed to be in an acute care bed in a hospital, and 5% needed intensive care. When you start at that in large numbers, percentage become way more than what's needed to control. I believe I read recently that I think it was the outbreak in Italy, I'm not sure. If they could have had all the ICU beds of the US, that would have been not enough for what they needed. So that gives you a measure of how these critical needs and overwhelming situation in hospitals are. Now, they are working very hard to improve their ability to cope with the cases. There are multiple things that are being done, such as building new hospitals. It's done in New York, it's considered here too. But that's not all, you also need the staff to run that. acquiring supplies. And for example, we hear about respirators that are needed for some of the patients in ICU. There's a shortage of respirators in the country. Even if you add, the simpler respirator, enough, even if you add what's in the national stockpile, which has about 40,000 respirators, that's still not enough. So that's why you see I was going to say order. The president and the governor, they have orders to make people do certain things. So repurposing certain factories to produce that are needed to respond to the outbreak. So that's personal protective equipment. In normal days, 50% of personal protective equipment that we use in the US come from China. These factories closed during the outbreak. They produce now 12 times what they used to produce, but the whole world is in need of personal protective equipment. So the situation will probably improve, but it's taking time. That's where it's critical to get that time. Getting respirators from factories who are repurposed to produce them, that takes time too. So every week that's gained in hospitals is helpful. They also are changing the use of certain beds. They turn acute beds into extra ICU. They do multiple types of approach to try to get better capacity, but the timing is critical. And so the mitigation is really, the main goal is not so much, the number might not be hugely different from what you would have seen in absence of control measures, but buying time is critical. And what results from that is a longer duration that increases. So you've all seen these curves with a sharp increase followed by a sharp decrease over a period of several weeks. It can be 2 to 3 months. When you start applying mitigation measures, the number of cases does not increase as fast, but the duration of the wave is longer. And that's where when we hear about restrictions for 3 weeks or so, that's not enough. And so it's going to be an extremely difficult decision. At some point, what is the social cost? What is the economic cost of, and that's what the president was saying a few days ago, talking about the remedy being worse than the cure being worse than the illness. It's not an easy decision. So public health officials and along with statistician, modelists, and all the experts that have knowledge that's useful to consider to determine what are the possible response to that builds an array of measures, and the difficult decisions are taken at the highest level. For us in North Carolina, it's the governor power that come to him as a result of the state of emergency that we saw in an emergency order a few days ago. I've never lived in a period where there are so many emergency orders, and get ready for more, and some that are really going to be extensive. I don't even know what's going to be in them, but that is because it's a number of people participating in putting these emergency orders together. But that's all geared at what is the best thing we can do to improve the capacity of hospitals to cope with the new cases and to protect people who are most at risk. Back to the case fatality rate, everything I said was average. But if you start looking at people who are at higher risk of severe course, like age more than 80, case fatality 1% in age more than 80 in the large Chinese series. People who have chronic lung and heart disease, people who have diabetes, people who are immunosuppressed. Just think of how many people are on cancer treatment, or just, this is a very large number in our community. And so everything, as hard as it is oriented toward doing the best we can to protect the most vulnerable people. because we've seen even with, talking of a case fatality rate, the absolute numbers are still extremely high. So that was a lot. Can you still hear me? I'll verify that.
Yes.
Okay, great. So I think we're at 30. I've got a few more remarks, and then hopefully we can go through the questions. So I've talked about symptomatic versus asymptomatic, very much talked about apparently from what I gather. I don't read the social media, that it's a lot in a lot of discussions. It's also in the news, and now the news and you have to be cautious with your sources. Usually from our standpoint in the public health group level, we're going to look at the CDC, the World Health Organization, some other groups that we know have knowledge and expertise, but cautious about things that come out of the blue, because there's lots and lots of things people can, and it's not necessarily that these are wrong information, but the context of the relative weight in understanding the disease is usually absent. So when you hear things asymptomatic, definitely we want to learn more, but it's not yet known. It takes studies to do that. Studies, why? Because as I said earlier, we don't have enough tests to do it broad, large scale right now. So I talked about the hospital, the PPE, the treatment. So another thing, so when I talk about, be careful about the study, the source of information that you get, we hear about people talking about certain experimental treatments, but the theory, and both good medical publications, reputable journals based on these of 5 patients, 9 for very information, sometimes very granular, a lot of details that are useful to think of other studies, but you can't make broad assessments for what's the general situation based on anecdotal reports like that. And for some consideration for treatment, let's talk about treatment for a moment. They're different. You've probably all heard about chloroquine. If you've lived in malaria endemic decades ago, you probably took your chloroquine every day. Well, chloroquine and hydroxychloroquine seem to offer an interesting therapeutic effect, mostly in increasing the level of inflammation, but they are not innocuous drugs. They can result in some cardiac conductions, and some people are more prone to get these side effects that can be really serious. And especially when combined with erythromycin, an antibiotic, which can also compound these heart conduction problems. So from the medical angle, you'd want to make sure you've taken care of verifying with an EKG, maybe that you're not having a patient who would be a lot more at risk for these conduction problems. There are other types, so there are certain antivirals. Some were used for HIV, certain combinations. There's been some already studied and kind of disappointing because they didn't seem to make much difference. Back to the anecdotal effect, what you do when you want to study a new drug, it's very important to think of it in an unbiased way. And the way to do that in the research world is to do a clinical trial, a randomized clinical trial where you have, you're biased in terms of who you give the new treatment to. You're not trying to make sure you have comparison groups, and you conduct that in such a way that you really try to measure as objectively as possible whether the true efficacy of a drug or a treatment. If you have a series of 9 people or 5 people who received convalescent plasma, for example, people who have survived the disease, you take their plasma, they have antibodies directed against COVID. They survived. They mounted their defense. You can use this plasma to try to help a current patient. 5 patients is not sufficient to understand how that works. We've seen it during Ebola. It's been used too. And then beyond the convalescent plasma, you can also try to produce the specific antibody, monoclonal antibodies. They're used in some cancer treatments. We have people here in North Carolina who are working very, very hard right now to try to produce monoclonal antibodies directed at COVID, and that hopefully will help. But again, we're at the inception of that. Now going beyond, just the last word about chloroquine. So there is, I said chloroquine and hydroxychloroquine. Apparently there's chloroquine phosphate that's used for certain aquarium treatments. People who have fish at home, and that takes care of certain problems with fish in aquariums. Well, there's already a report of a person in the US who was so panicked that he ingested some of that type of product and died of intoxication with that. So again, word of caution about rushing to certain treatments. There's also things that have been said, like, is it dangerous to take ibuprofen? Or certain and sometimes so you hear politicians. President Trump talked about chloroquine. The Prime Minister in France talked about the use of ibuprofen. Oui.
I am going to stop you for a second because you were talking about ibuprofen, but your picture stopped, and I don't think anybody heard your answer.
Oh, I'm sorry. So, thank you. What I was saying is the concerns about ibuprofen have been mostly theoretical. There's not really data to say it's a real risk.
But you still think it's not advisable to take it?
Yeah, well, it's better not to take it, but it has to do with the type of receptors that the virus uses to bind to lung cells, and the effect that some drugs have on these. And I see that my internet connection is not great, so I hope we don't get cut, but thank you. Now, last thing that I would like to talk about is the vaccine. You've probably all heard Anthony Fauci, the director of the National Institute of Health, talk about cancer that appeared to have been obtained very rapidly by recombination. I mean, the technology today helps a lot. It's one thing. He also, the second part of his statement was to put a new vaccine on the market takes many months. There are successive trials done, 3 successive waves to verify safety, efficacy, side effects, things like that, and the series on people, the number of people tested increases with each of these trials. That takes a long time, and that's why he ended his statement by, if it works, and we'll go back to that, we need another 12 to 15 months at least. Now, things are extreme. Some of the trials that normally take 6 to 9 months to place have been cleared within 4 days. That gives you a measure of the extraordinary period that we live in circumstances. I don't know whether anyone will manage to do the same kind of, manage to find ways to safely go much faster. We all wish for that. The problem that it creates is when you think of mitigation, going back to where we started, if you relax the mitigation measures, see cases go up again. And for as long as we don't have a vaccine, the only thing that gradually protects us is the proportion of the population that has had the disease and is immune. Not a great way, but that's what it's been in the pre-vaccine era. And so for as long, now the next part, and I'm not a vaccinologist or vaccine expert, but we also hear that coronaviruses have a tendency, just like the flu actually, to have a different antigenic constitution. And that's why we need a new flu vaccine every year, because we're not dealing with the same flu strain every year. Well, if the same happens with this coronavirus, if we get an effective vaccine, which is, we don't know. There are, by the way, there are at least 7 other candidates that are, and it's very nice to read that there are more vaccine candidates being studied, because it's absolutely not sure that the first one will be the good one. We've lived for decades. I mean, for over 30 years now, I've seen wishes that we would get a vaccine against malaria, for example, and sometimes we've been close and we're still waiting. So vaccine under study is a good thing. Whether it works and then can lead to large-scale production, we'll see. And one reason everybody is cautious in production of vaccine is things can go wrong. If you remember the polio outbreak of 1955, I don't know how many but we can read about it. There was a lot that was not sufficiently inactivated and actually gave polio to a number of children vaccinated, some of whom died. And these cases had secondary cases, and some of those secondary cases died too. So, the prudence and the regulatory aspect of vaccine production has, that kind of background. It's based on, there are good reasons. Mostly, if things can be changed and accelerated, we are witnessing that this is done. But you can't ignore all the precautions that are in place. So that was my introduction. It was fairly long. It's 5:47, so let's go to question and answers now. Marie-Claire, you want to help us with that?
Yes.
Thank you.
Definitely. There are lots of questions. Start my video. Okay, apparently I can start my video, so you have to allow me. So, okay, so I'll ask the questions without the video. So the first question was, when will the simple testing procedures be available in North Carolina?
So we don't have enough tests. Yes, that's true. But people are working really, really hard. Just an example, this morning, the director of the state lab, which was the first lab to do COVID testing for North Carolina, told us that they just implemented a new way, a high throughput technology for the first step of testing, which will allow them to test a lot more cases. The same is true with commercial labs. They are gearing up as fast as they can. This amplification step, the initial step to be able to have better technology that allow to process more specimens faster, but we're not there yet. And just a word about, it was great to hear that very large commercial labs were on board. And here we also heard that their turnaround time is not great, and the reason is it's well beyond their capacity, and they have 10,000 tests that are waiting to be tested. It doesn't mean they stay there forever. You get your results within a few days, maybe 5 or 8 or 3, but that gives you a sense of, I can't answer the question with the time, but I know a lot of people are working hard to improve the situation.
Je vois que vous avez répondu à beaucoup de questions. Merci beaucoup, c'est génial. Moi, j'ai une question très pratique. Je ne sais pas si vous pouvez y répondre, mais en fait, parce que je ne sais pas où vous pouvez taper la réponse, mais en fait, on dit de laver, en France, ils disent de laver toutes les surfaces, tout ce qu'on achète. Par exemple, quand on va faire des courses, on achète des choses qui sont emballées. Quand on ouvre les portes, etc. Donc, je veux dire, est-ce qu'il faut je ne sais pas vraiment comment on peut se protéger contre tout ça. Est-ce qu'il faut laver tout ce qu'on a mis à la maison? J'ai des amis à qui on a conseillé en France de laver toutes les surfaces de tout ce qu'ils amenaient chez eux. Donc,
Difficile. Euh, Encore une fois, l'essentiel, c'est surtout de se laver les mains souvent. La désinfection avec un produit chloré.
maybe we'll have to do it in English. I'm sorry, because I realize there are still people. So my question was, how can we protect ourselves? People are saying that we have to wash everything, especially friends in France, like wash every surface that of all the stuff that we brought from our shopping trips, plastic, metal, etc. So what is the solution? I mean, it becomes a little crazy, but should we do it?
It's hard to tell for sure. I mean, what results in contaminating a surface is mostly you would expect a person who's shedding a lot of virus when they sneeze, when they cough.
Yes.
So the risk is not universal, but it's hard to know. That said, thing is there are many products that are efficient against this virus. It has a lipid membrane around it. The envelope is lipidic. And so the alcohol content of hand rubs, so long as it's higher than 60%, is sufficient to damage the virus to a point that it becomes inactive.
Okay.
And hand washing frequently for long enough is really the closest line of protection that you can have. Now,
but if someone sneezed on a like let's say I'm going to the store, I'm buying a cauliflower, someone sneezed on it, I mean, I'm gonna wash it with water, but it's not gonna make it go away. So I mean, I think people are going crazy because they don't know what to do and what's sufficient.
Yeah, that's not an easy question to answer. I think, I mean, it also depends with how intense the outbreak is in the place where you live. In New York today, maybe it's a real concern. In North Carolina, we do have cases in the community, in most counties by now. How much that resulted, I mean, I think there's a gradation of the likelihood. Now, if you have a plastic surface that's easy to wipe with a chlorine cloth, yes, fine. But then you come to porous surfaces where it's less easy to do that. Maybe sprays you can use too. So not an easy question to answer.
Okay, well, yeah, thank you, because that's one of the main concerns. And you say that one of your questions that probably 2-3 weeks is not enough. I mean, how long do you think we should be confined to make it work worldwide? I mean, everywhere.
Well, that's where you'll have politicians making the hard decisions. So what we know from the health side of that really tough is when these measures are lifted or gradually partially lifted, we see an increase in cases because the conditions for transmission become more common again. So I don't know. I don't have a crystal ball. I don't know how long it will be maintained. Yes, there's a point where it becomes economically untenable. I don't know where that is exactly.
But still, at the moment, you think that what everyone is doing, restricting people, that's the best policy for the moment.
It helps tremendously right now. It does help enormously for improving the situation.
Okay.
And the modelers that are putting all the that they can think of in models to try to predict the best circumstances, and that's what people the secretary and the government are showing with the different intervention when you reach a level of need for intensive care that becomes more than what was available in the state.
Yeah.
Now, I've said there are a number of things that are done to try to increase that number. So it's nothing is perfect or exact, but the more time hospital and others have to plan. For example, when we talk about new hospitals, we have the space in North Carolina. It's not so much a matter of the place, and the money will be there. It's just like you need the equipment and the staff then, and the PPE. And so time helps with these enormous decisions. The Chinese built a couple of hospitals in a few days. That's never, I've never seen that anywhere before. I've seen, prefab units being used to build buildings, but a whole hospital in 10 days, that's unheard of as far as I know.
Wow.
And we may have some of that. Places like Singapore and very few places have gone to an extent. China did that too. It's in addition to working in hospitals, and maybe a halfway to the tough measures that we are under now, is to put persons who are sick but not sick to the point they need to be in a hospital, or people who are recovering and don't need to be kept in a hospital, but it would be safer to have them in a dedicated location. So some countries have done that. That's going to a level that is not where we are now. That could be a half measure. Like if you have it, you need to be in that hotel that the state bought or something like that until you're proven to be negative. There are two ways to stop isolation. One is based on testing the person, and you want 2 tests that are negative at least 24 hours apart. The other currently is if you are more than 7 days after your onset of symptoms, the date you became sick, and you're also at least 3 days or more from resolution, which is defined as no fever in the absence of medications to bring down the temperature, and your respiratory symptoms are improving, then you can be released from isolation. So that's the technique without lab test. And so, all of that can be used. And if there's a need to recalibrate, if for example, we saw that usually when you see recommendations from CDC, they don't give them prematurely. They have data to support what becomes guidance. So that's what we use. And actually, one thing I didn't say because I skipped my mind when I was speaking, but SARS was a new virus in 2003, and we were faced with a number of questions that were similar, except we didn't have that many cases. After SARS, we changed the law in North Carolina to write in the administrative code rule about disease control that if a disease is not in existing medical books, we use the American Public Health Association manual for communicable disease control, for example, and also not covered in existing rules, other rules of the administrative code, then in North Carolina, we will follow published guidance from CDC. And that was directly from SARS when we deal with a situation where the science didn't exist. So we have to rely on new decisions, new understandings, and the best source by far is CDC, because they spend the amount of effort necessary to come up with data to make the decisions, to come up with the guidance and what should be done in certain situations.
That's a very good answer, great answer. Thank you so much. And then one last one, just to finish. I mean, someone mentioned, what can we do to up our immune systems? I mean, to boost them. Is there anything we can do apart from staying away? And I understand that.
I don't know, and that's where it starts shifting to the anecdotal. I mean, you'll have a myriad of people who will give you many answers to that, and I'm not saying it's bad, but it's not the field where I really know much. I've read that in New York City, where they have a lot of cases, one thing that they are doing is giving high dose of vitamin C to many patients. And I'm not sure whether it's part of a trial or whether they've already observed that it seems to help. I wouldn't say, I wouldn't say that as a patient that I could explain, because I've just read that as part of a news media report. If it becomes something that's covered in medical publication, peer-reviewed journals, then that will be much more of something to consider. But that's just a partial answer.
Yeah, well, that's always interesting. I mean, it's just interesting to know if anybody's thinking of some things, or because we're, as you say, there's so much information all over the internet. Everyone is drowning in information. Everyone talks about it. The news media are talking about it all day long, and we have so much bad or false information everywhere. So thank you very much for putting everything a little bit in perspective and giving us a scientific outlook at the situation. We really, really appreciate your time